the meeting to order. Shall we say the Pledge of Allegiance, please? I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right. Can we have the roll call, please?
Glenn Bailey. Peggy Kavala.
Here.
Dr. Johnson.
Here.
Dr. Noland.
Here.
Commissioner Cowles.
Here.
Commissioner Bertling. Chairman Fletcher.
Here. Public comments? Anyone want to make any public comments? Commissioner Corn, I'm actually going to call on you later specifically, but you're always welcome to speak beforehand.
I appreciate being here.
We also appreciate your being here. Any other? All right, well then let's go to the consent agenda. Let me ask about C, Panhandle Health District Program updates. How detailed is that?
Well, every month, each of the program managers will provide a summary of what has happened in the prior month, what activities that their programs have been taking. So that is included as a standard portion of the
Yeah, it comes out.
agenda.
All right. And then we have fiscal report, but we're going to go into a lot of fiscal report with the budget review. I mean, that's going to get looked at ad nauseum today. Is there anyone who wants to extract any of those items for particular attention? Hearing no extractions, I will entertain a motion to accept the consent agenda.
A motion to accept the consent agenda.
Is there a second?
I'll second it.
Are there any objections to acceptance of the consent agenda? Hearing none, I'll let the record stand that the consent agenda passed unanimously. Okay, Jason, I think you're up next. Just as a quickie here, when the Finance Committee was going through all of the various departments, and it was discovered that the septic program was, well, the environmental quality consists of several elements. The food handling component, the fees that are extracted from the community, from the restaurants and the food handlers, is all fixed statutorily. Boise fixes it. But the septic permits, apparently we have some measure of control. And so for all practical purposes, what the Finance Committee discovered is that we have been asking of the county commissioners to subsidize the septic permits for people building homes. And we said, well, why are we doing that? And as a matter of fact, upon further review, the fees are way in arrears as to what they could be. And Jason is now going to give you the details. And the good news for the county commissioners and the taxpayers is you won't be subsidizing septic permits. Okay, Jason, go for it. Thank you for your work here.
Okay, yes. Thank you, Dr. Fletcher. That's a great introduction. I'll keep this very brief. I know it's
a long meeting.
Yes.
You could just tell us how much money we're saving and we'll accept it.
Yeah, I mean, we could do that, but I'll go through this briefly. And so, yeah, just some background information. Dr. Fletcher articulated that well. Really, the goal of this proposed agenda item is to revise fees in the septic program to achieve budget neutrality for the septic program. Septic program is entirely fee-based. And so any fees that do not cover the cost of the program, then or any costs that aren't covered by then fall to the counties for county support. And then the reality is that the fees have not kept pace with construction, housing costs, or cost of living increases. For example, since about 2010, average for the 5 northern counties, we've seen about 170% increase. Some areas much more than that. In housing costs, the septic permit fees have been increased only about 20% in that time. The last fee increase that we had was in 2022, just for some background. And then just as Dr. Fletcher mentioned, there has been an increase in county support in recent years in the septic program. Fiscal year 2025, for example, was a $340,000 total in district support. And so just as Dr. Fletcher mentioned, when we developed the FY27 budget, the draft budget that we proposed includes these fee revisions to achieve that budget neutrality. Without the fee changes and really scaling everything back to the bare minimum, that translates to would translate to about $250,000 in county support, based on projections over FY27. And then, yeah, Dr. Fletcher mentioned this, but there's really two programs in the environmental health section that have required county support. In the food program, as Dr. Fletcher mentioned, those fees are set directly in statute. We cannot change them. They only cover about 50% of the cost of the program statewide. The septic program, we do have the ability to change fees through Idaho statute 39-414. And in that statute, it allows us to set fees that reflect the actual cost of the program. So kind of walk through that a little bit. The justification for the fee change is that the proposed fees were all set based on a detailed analysis of staff time in the program. We have a very robust time coding system in the environmental health section to capture these elements. And so basically staff code time for all the different fee categories on the fee schedule, and then look at detailed analyses of those over the course of fiscal years, and then adjust the fees as necessary. That's the general process, and that's how these fees are arrived at across the state of Idaho. And the other thing that's important to know as board members is the septic program is a very technical and dynamic program. This is not just a paperwork shuffling up exercise where we're just reviewing plans and stamping them and approving them. It requires a lot of field work that many of surrounding states, and really many states in the U.S. at this point, outsource through consultants. So a lot of the work that's done by environmental health specialists in the septic program requires a lot of expertise, a lot of trainings, high skill, and again, those are outsourced. And doing some analysis that can translate to anywhere between $1,500 to $5,000 just in consulting costs that are included in our septic program fees in surrounding states in Montana and Washington, and that's really on the lower end of that. And then in terms of the consultants, there's consultants required for the site evaluation portion, which includes certified soil scientists, and then designer requirements to design the septic systems. Idaho does not have either of those requirements. And so other than about 15% of the septic permits on the upper end that we issue, they do not have a designer requirement, and that design responsibility falls to the applicant, but we have a very active role in that design. So it's really working together with the applicants, homeowners even. We work on a lot of homeowner installs. So there's a lot of work that goes into this program in the field, even including many of the sites that we work on require ground and surface water monitoring, just to make sure that septic systems are going to function properly, meet setbacks. And then the other reality is that we've had a big increase in staff time on large projects as our area has been growing over the recent years. It's been a really big shift since about 2020, 21. That includes a lot of work that does not translate to fees with existing community systems. Many of these systems are very old, over capacity, don't meet current standards. We have the most community systems in the state of Idaho, and there's just a lot of time continually with those. We continue to have a lot of proposed revisions to large projects, especially in the outlying counties, in Commissioner Cowles County, for example, and Shoshone County, working through, as properties either change hands or, for example, last year, the Big Eddy, a big restaurant on the St. Joe River, burned down, and working with the current owner on that as they're working through that. Those are all activities that consume a lot of staff time that don't translate to fees. And then the other reality over the last, let's say 5 to 6 years is a large increase in non-compliance, complaints, and then also some litigation. So included in this review is also an analysis with other health districts. And one of the differences with Panhandle Health District from other districts is that we no longer charge fees for building permit review. So we're very integrated into county building and planning processes. And so FY25, for example, we reviewed just in Bonner and Kootenai counties alone, over 3,100 building permit reviews. And again, that does not translate to fee. And the purpose of that is ensuring that the construction projects match both the county requirements and the state of Idaho requirements. So we integrate closely with the counties for that. And from a staff time standpoint, the environmental health staff spend the equivalent of one full-time FTE environmental health specialist per year across all 5 counties doing project reviews for counties. So just wanted to highlight that because that is a difference between Panhandle Health District and other counties. The building permit fees were eliminated, review fees were eliminated in 2019 for just some background. Okay, so the specific proposal would be to approve the revised fee schedule effective July 1st, so which would put that into effect for fiscal year 2027. That gives us time to message this to other stakeholders in the program. And then the fee revisions are shown here, as well as there's also the same table is in the board packet. So we can go through each of these individually if you'd like, or okay. So yeah, so that's really all I had. It's really fairly straightforward. The bottom line is we're just trying to make the septic program achieve budget neutrality, just to cover the costs in the program. The fees reflect the actual time that we spent in the program and have been proposed to adjust for that. So I don't know if you have any questions or.
Well, I'd like to thank you for doing that detailed analysis because the pushback is not going to come from the county commissioners. The pushback is going to come from the folks making application.
Mhm.
I mean, if you're building a house and you go, well, gee, how come I'm spending so much money? Well, you've done the research to justify why the fee structure is what it is. So I want to thank you for putting that analysis into it. Peggy?
Yes, Jason, so under the fee category, the central system,
Yes.
so when you look at the current fee, and then there's the additional with the field work, on average, what does that fee turn out to be?
That's a very difficult question to answer. So that's what I was referring to with the large community systems. And so just from perspective, we have 70 in our area, and those are defined as essentially 10 homes or more. Only one of those meets current standards. So most of the work that's been done on these systems has been previous systems that really aren't tied to fees. And so the reason it's set up like that is it can be really straightforward in some cases. Other cases, for example, we worked on one in the Twin Lakes area in Kootenai County where they're proposing a system like that on a solid rock, bedrock, basically mountaintop, and it took considerable amount of staff field work. So that's really for those situations where they have the option of essentially using our staff as consultants versus hiring an outside professional geologist, soil scientist, something like that, identify a proposed site, and then we could review that. So it's really set up to allow some flexibility in the process, so that because these can range. For example, we do not have any large soil absorption systems that we permitted in Benoit County. Just to give you an idea on that most of them are 1990s and previous to that. So that we structured it that way to allow for, so that straightforward projects, if it takes minimal site evaluation, has a reduced fee, but then if it expands beyond that and takes considerable time, then those fees are recovered through that essentially consulting fee.
And maybe if I could add to that, the other fees are pretty straightforward for us to calculate because we get hundreds of them a year, so we can make a pretty good average. LSAS applications are less than 5 a year, in some cases 1 or 2. So some of them take a tremendous amount of time, some of them take very little time. So giving you a good solid average is hard to do in that.
Yeah, and the other thing on that, really quick, that I'd add is that many of these projects start as proposals and don't progress to the septic to actually becoming a permit. We recently worked on one in Bonner County at Camp Bay where they proposed one of that system type, worked through several months of revisions with the applicant and engineers. They scaled that back, and we did not end up issuing a permit. So that's also why we have as a tiered fee approach so that they would not have to pay for the permit unless they're actually going to proceed towards the permit, if that makes sense.
Yeah, I have a question that, thank you very much, Jason, for your explanation that, if I remember correctly, that you were saying that the costs had gone up something like, was it 170%? Is that what you said, or?
That's what my
And-
research showed, which is challenging to, across 5 counties and,
No, I get it, but the fees had only gone up like 20%. So obviously with a dramatic increase in income this upcoming year, fiscal year 27, that obviously there was some money substantially that was lost between 22 and 27. Going forward, do you have something in motion that'll kind of keep up with it every year so that we don't fall behind like that?
Yes.
I might have missed that, but I just
Yes,
wanted to
yeah, that's
clarify.
an excellent point. Thank you for bringing that up, Commissioner Johnson. Yes, we have not revised fees since 2022, and so that's really what my preference would be, to make this do this analysis every year, adjust either way. It may go up, it may go down, but to actually set the fees, based
Annually
on-
then,
Mhm.
to make
Yes,
sure we're on-
absolutely.
Okay, good.
And maybe to add a little bit to that is that one of the reasons that we've been cautious about changing the fees with frequency is because we get compared with other districts and other areas, and legislators have done that in the past, and it creates a whole nother. So we try to make those adjustments incrementally over time, but certainly if this board wants to make them on a more frequent basis, we certainly can. We do that assessment on fees and revenue. It's an ongoing one, certainly done at a minimum annually.
Yes.
Well, I would suggest it because in essence, what's happening is everyone in Kootenai County then, if it's money is coming from the commissioners, it's coming from the taxpayers. So everyone in the county is paying for someone who's moving in. We're helping to buy their house. I mean, that doesn't make any sense. I don't think I should be buying somebody else's house. Functionally, that's what's occurring. So for sure. And if people poo-poo that idea, well, then I'm sorry, that's just the way the fees, if you want to live here, these are the fees, period. They're proven to be equitable. They're reasonable. This is life. I mean, costs have gone up. You got to pay it. Either you pay it or I pay it. I'd much rather have you pay it.
Absolutely. And that is,
Touche.
that's an excellent point. And really, that's the reason that these are not subsidized by the state of Idaho. Fundamentally, Idaho legislature wants development to pay for itself, to not be on the backs of the county taxpayers. And then, just as Eric said, we propose these fee increases reluctantly. We understand the fiscal impact to people. Everybody, how housing costs are already rising very rapidly. And so that is part of the reason for the delay since 2022, is that we are very sensitive to that. But at the same time, it's as county budgets are more constrained, and this would, just to make it more budget neutral, just to alleviate that financial impact to the county. So
Any other questions?
So just to clarify, with the 340 versus the 250, is that the difference? So you're saying basically what would be the amount that wouldn't need to be asked by going budget neutral with the new fees?
based on the projections for the FY27 budget, the septic program would be budget neutral. It is challenging to project, so much of it is based on the general economy, the
Okay.
housing market and so forth. But based on projected numbers, the fees were set to cover our costs, and then also to balance, to become budget neutral.
Okay, and so then last year it was 340,000 in the rears. So that would be 340,000 that potentially would not need to be requested from the commission.
Yes, absolutely. Thank you.
Commissioner Corn?
So when I'm hearing you talk about it being subsidized by the counties, is that through a line item on your budget that we accept on an annual basis? So moving forward, Panhandle Health is looking to be budget neutral on the fees. Therefore, we would drop that line on the budget for environmental services. Or I don't know how the lines work accepting other environmental services.
And maybe to clarify, there are a number of programs we have in environmental services. So when Christine gets to that portion of the presentation, there is still a component that does need county dollars, but that's predominantly the food program so it's not specific, it's kind of captured in all costs, but it is
if you have more questions, when we get to that point, we can certainly break that out. for you.
Yes, yep. But the nutshell is that we are, yes, absolutely making the programs that we have the ability to make budget neutral. We're proposing to do that, and that we don't have any. Yes, absolutely. Yep.
It'll happen. Any other questions? Hearing none. Agenda item 7 is to. Yes?
Chairman, if I may, this is an action item because we do need the board's authority to adjust the fees, and we do have to notice that before they go
Oh,
into
valid
effect.
point. I'm sorry. Yes. Okay, so in order to execute that, we need a vote.
Okay, how would that read? I can do that. I think it's a great idea.
Um,
I make a motion to adopt the new proposed fee structure as proposed from Jason from the Environmental Health Septic Program fee revision proposal on page 27, and that we make that our new fee system.
Do I hear a second?
I second that motion.
That's right. This is a no-brainer. Any further discussion? Hearing none, roll call vote.
Peggy Cavallo,
Yes.
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Commissioner Cowles,
Yes.
Chairman Fletcher.
Yes. Okay. Now we move to item 7. We're going to migrate into executive session. Let me well, first of all, we'll need a motion and a second to go into executive session. And then, Jessica, if you'd be so kind as to get,
Yeah, I did. He said he's logging in now.
he's logging in now?
Mhm.
Perfect, thank you. Well, let's get him on the line. In the meantime, this will be board members only. Do I hear a motion to go into executive session?
I would make that motion.
Do I hear a second?
I second.
Code 74-206. L and F.
Okay,
Says legal.
I think it's
any
1F,
discussion?
Yeah.
Yeah, I think it's 1F.
I second that to go into executive session based off of Idaho Code 74-2061F.
Any discussion? Roll call vote?
Peggy Cavallo,
Yes.
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Commissioner Cowles,
Yes.
Chairman Fletcher.
Yes. Okay, so do we have Mauricio on the line?
Not yet.
Okay. Well, everyone leave. Meeting to order. And I'll take a motion to call the meeting to order.
I'd like to make a motion to call the meeting to order.
And a second.
I'll second that.
Okay, roll call vote.
I lost my page. Bear with me. Who was the first? I apologize. First was Nolan?
Yes.
Okay.
Duke?
I'm going.
Wait, Johnson, I think you made the motion.
I made the motion.
And I seconded
You
it.
seconded
I
it.
thought you were
Okay.
roll call.
Roll call vote.
Peggy Kavala,
Yes.
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Commissioner Cowles,
Yes.
Chairman Fletcher.
Yes. All right, we're back in session. Eric, we did discuss the liability issue. So do I hear a motion then to accept this contract?
I make a motion to accept the contract representation agreement with Dobler Law Group for the legal services, and including the fee structure and retainer structure described in that.
Do I hear a second?
I'd like to second it.
Roll call vote. Oh, well, any discussion, further discussion? Okay, roll call vote.
Peggy Kavala,
Yes.
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Commissioner Cowles,
Yes.
Chairman Fletcher.
Yes. Okay. Item 10. So this is actually an old issue. The county seeks to expand the clinical program to actually perform, if you will, conventional allopathic medicine as well as integrative medicine. Now, many of the integrative medical interventions or treatment protocols do not have traditional CPT codes, and so therefore you can't do typical billing, CPT code-driven billing. And as a consequence, we'll have to have a parallel fee-for-service or potentially even a concierge payment mechanism. So now the question arises, can you have in a single clinic third-party billing specifically to CMS as well as fee-for-service? Now, according to the AI products that I've queried, you can. You have to do things just right, but you can do it. Now, Commissioner Domke has asked me to actually get a legal opinion on this because it may happen, and I am not going to put words in the mouth of the Bonner County Commissioners, but it may happen that Panhandle Health could be subcontracted to provide concierge services for their county employees. The probability of this happening, I'm not going to assign a number, but Commissioner Domke would at least like to know, is it legal before we even begin a conversation? I think it's a perfectly reasonable request.
Yeah.
So we need to get a lawyer. It's not enough that I ask, Grok. We're going to get a lawyer and give us an opinion. Now, I came to the group with this request a month ago, and we found someone, and I was given the instructions that I could only talk to that one lawyer. I spoke to that one lawyer, and he said, well, I can do the job, but my fee schedule is pretty expensive. May I give you the names of some other people? I've not called the other people. So I'm coming back asking Mother, can I spend, no more than $5,000. I cannot imagine that this is an expensive thing to answer this very specific question having to do with CMS billing.
I make a motion to allow the chairman to pursue specialty legal services for answering this question on whether or not we can do a combined CMS billing with a integrative medicine model in the same clinic, and with a cap initially of $5,000.
Fine. Do I hear a second?
I'll second that.
Any discussion? Hearing none, roll call vote.
Peggy Kabala,
I'm going to abstain.
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Commissioner Kells,
Yes.
Chairman Fletcher.
Yes. Okay, thank you, everyone. Next, number 11 has to do with Finance Committee report. Let me make a couple of overview comments, and then I'm going to turn the program over to Christine. Overview comments is I want to thank the Finance Committee subgroup members. We met a good 10 hours. And, in the case of someone like Peggy, it takes her an hour and a half to get from home to here.
Yeah.
So when you spend then another 2 or 3 hours, some of these afternoons, we didn't leave until very late. So,
They were a full day.
Thanks.
yeah. So I just want you to know there was real work that went into this. It wasn't just baloney. And you've already seen some of the results of it as Jason gave us an outline. All right. Another couple of items to say at an overview level is we looked at numbers. We did not look at efficacy of the programs. Let me repeat myself. As I was listening to some of these numbers coming out and all of the activities and whatnot, being kind of an ingrained doctor, I'm always looking for outcomes. Is what I'm doing making a difference? This budget does not answer that question. You just need to know that. In the long run, I'm going to insist that we address that. Now, I don't know if it's going to be the Finance Committee or we have some other subgroups. I mean, I'm going to assume that Jason is a perfectly reasonable human being and that in fact he's doing what he says he's doing. But his numbers do not reflect the efficacy, the quality of the product. You see what I'm saying? And moving forward, as your chairman, we're going to answer that question.
I think it's an excellent point because any business that invests any amount of money needs to have feedback as to the efficacy of the money being spent. And I
Yes.
think most businesses operate that way. Governmental agencies do not have a tendency to operate that way, but independent businesses do. So that makes perfect sense.
Yeah. And you see, I'm going, typically, historically, the director has gone on the dog and pony show to the counties to present the numbers to the county commissioners, with their hands held out saying, please give me money. And it's not a trivial sum. We're going to get $2.2 million from the commissioners. It's 25% of our budget. So this is a measurable, contribution. Now, in a sense, I'm going to have to I'm going to go with Eric this year. I'm going to be a part of the dog and pony show.
Oh, good.
I would invite, by the way, any other board members to go. Certainly, I expect the board members of the county that we're delivering the dog and pony show to be there. So when we go to Kootenai County, I really do want one or both of you to be there at the same time. You're the dudes. And Peggy, same thing with you. In fact, apparently your county commissioners are turning over. They may not even be the same board a year from now. Well, in any event, but you see where I'm going. We need board members to be up and present. And here's where, if you're going to ask for money, I think a necessary component of this will be we're spending your money wisely. In a sense, I'm going to have to commit a lie of omission. And I'm going to go, quite frankly, I don't have outcome data, but you know what? Next year, I'm going to do better, is how I'm going to put it. Does that make sense? Does that resonate?
Yeah,
Perfect
it does.
sense. Yep.
All right. One last thing, overview, is when Christine gives the numbers, you're going to notice that the clinic program as proposed by Dr. Pinnock is in a hole. It's $500,000 deficit spending. Now, there's more to the story than that it's deficit spending. I can either tell you why there's more to the story now, or I can wait until she delivers the numbers.
Yeah, we can wait.
Why don't we wait? So, given all of that, Peggy, do you have any comments to make about the Finance Committee?
No,
You were there.
we spent a lot of time,
We did.
and we met with all the departments.
That's great.
It was very informative. All the board members asked a lot of questions. And it was a nice way to be able to interface and engage with the staff.
Yeah, I would agree
And
with
to
that.
learn more about their programs
Mhm.
and how they reach out to the communities.
In conjunction with that, I want to say that I never got the feeling that there were any department heads that weren't themselves emotionally committed. I mean, I think you have pretty darn good staff. I just want to say that. Does that resonate with you, Peggy?
Very much so.
And probably the best outcome of all of this is Peggy started smiling. All right, Christine, you're up.
Chairman, if I could preface the conversation just a little bit, and one thing I hadn't planned on, but just to touch on the efficacy, just so the board knows, certainly welcome to any ideas that this board has on how we can demonstrate, what we're doing with the funding, but just to share, with the vast majority of the funding that we get, it's contracts that has defined deliverables. There's required reporting that we provide back to the state or to the funding source. In addition to that, I certainly welcome all board members to take a look at the program updates, which further provides very, down to earth items on what your staff are doing on a daily basis to provide services to the community. So again, certainly welcome new ideas, but I can say with confidence that we're running a lean operation and we're meeting the needs of the community. So with that, just to preface Christine's presentation, how we'd like to do that is, as has been mentioned, the Finance Subcommittee has gone through all of the programs, met with program leads in detail, has gone through literally where every single dollar is being spent. What you're going to see this morning or this afternoon is Christine's going to take that consolidated or all of those budget items, put it into a master budget set where all of those expenses are lined out. And she's basically going to walk through expenditures and revenues. And then you'll also see where county taxpayer dollars are going, what programs that those are going into. Because of the clinic being a significant change over past, we're actually going to have Karen, and I appreciate her being here, going into the same detail that the Finance Subcommittee has seen in regards to the expenditures associated with this new clinic build, so that everyone has a really good understanding of what how that budget is built. Just a few, I guess I'll call them housekeeping items that you'll see. We again kept it fairly lean. There is, after speaking with a number of county commissioners, we did revise the proposed 3% pay increase to staff to 2%. I mean, it's not lost on us looking at the state level that the state has leaned up a number of state programs. They're not seeing any pay increase. And because of that, I reached out to a number of county commissioners and said, how do you see your budgets being built? What do you support? What do you not support? And I got a few different answers. But generally speaking, 3% was not something that they could get on board with, but 2% was a more comfortable number. So we did take that into consideration, and you'll see that reflected in what Christine presents.
Eric, is that generally the COLA they're talking about when they're doing their budget, more or less?
Yeah, they call it different things, but yeah. We do have a one significant repair that you'll see in the budget under general support related to this building and the flat roof. It's in very poor repair, needs work. We've also put a couple of new vehicles in there to replace 15 to 20-year-old vehicles that are upwards of 200,000 miles. We're trying to keep the fleet reasonably reasonably current, I should say. I think that summarizes my comments.
Mhm.
So if you have questions for me, otherwise Christine will dive into the details.
Yeah, Eric, if I may, even though you guys are, see, I'm not aware of the standards that the governmental programs, the grant programs are requiring. So I mean, that would be good in the future for us to be informed. So even though you're fulfilling theirs, it'd be just great for us to be able to take a look at that efficacy.
And glad to do it.
Yeah.
Frankly, it's been a thing that staff, executive staff have talked about regularly,
Mhm.
but our meeting agendas have been built such that
Mhm.
there hasn't been meaningful time to get that to you. But
Sure.
But by all means, it's something we want to do.
Yeah, good.
Front and center, Christine.
Looking forward to it. So starting with the summary, and keep in mind, the budget is not yet balanced because of clinical. So what we currently have projected for total expenditures for fiscal year 27 is $12.3 million. And compare that to fiscal year 26 of $11,600,000, a change of $700,000, a 6% increase. This is where we are not balanced, and we will be discussing this here in detail in a short bit. So currently, without a balanced revenue side, we're looking at $11,800,000 compared to last year's of $11,500,000. So with those two numbers, it's a $276,000 difference. Again, we're out of balance, and this is what Dr. Fletcher was referring to earlier, what needs to be discussed in detail. We're out of balance by $428,600. What I'm going to do is I'm going to start looking at the general support budget, and I will explain in detail some of the items that we have budgeted for. Eric already touched on several of them. Then I will do a high-level review of the programs, and if you have specific questions related to those programs, we'll defer to the program manager to answer those questions. So how we build our budget, and this is the first time I have presented it in this level of detail, we break down the general support component to the Board of Health and then the 5 individual counties. So Board of Health, I have budgeted in total expenditures $7,100 based on your visits, 12 visits a month, or 1 visit a month times 12. Travel costs, your mileage, and also I built in here if you have any, those travel costs also equal if you choose to go to Boise or some of those events that you did in fiscal year 26. Those have been built in here. Benewah County, there are no significant changes in Benewah County with the exception of $52,800 built in here for the repair of the dry pipe portion of the fire sprinkler system. And Eric, would you like to expand on that?
Yeah, I can speak to that. There's a dry portion of the system that's near exterior walls, and so it's dry because otherwise it would freeze.
Right.
What has happened over the course of the last 5 or 6 years is that leaks will form because condensation builds up, and then it depressurizes that dry system, and then it can cause the system to activate essentially, and then it would flood various areas of the building. What we've been told by contractors that have looked at that is that a fairly cheap grade of pipe was used when that was installed, when the building was built, and that entire pipe, so they need to remove portions of fascia and different other things in order to get to the pipe, replace it with a heavier duty pipe. But they said we can expect ongoing problems with that system because of the pitting that's occurred over the past almost 20 years now since that building was built.
Have there actually been floods at the building or water damage or no?
There hasn't been any water damage as of yet. Because we've talked, one mitigating factor we took a few years ago was we installed the nitrogen system. So instead of air pressurizing that line, it's nitrogen, which is less prone to creating rust.
Yeah.
But they said that that's a bit of a Band-Aid. So we are looking to try to get that done before, any significant damage comes to the building.
Yeah.
Also included in here is $25,000 for trim painting on the building. I meant to load pictures. Our maintenance individual recently did pictures for us to take a look at. And we did have this budgeted a year or two ago, and we're unable to get the painting done at that point. So $25,000 just to do the trim work.
And Christine, is that from money that was set aside a couple years ago, or was that money then moved elsewhere?
The money was not spent previously.
Yeah, so it's not a new amount, it's amount from our savings.
Correct,
Okay.
correct.
Quick question on that. Do we know the approximate appraised value of the Benoit building?
Yes, we do, but I don't have it available.
Okay.
Risk management does an assessment every 5 years of those buildings, and it's a rotational visit looking at those. I can go into the risk management program and find out what they have assessed the building at.
Okay, thanks.
These are just basic expenses related to the operation of the building, administrative supplies like paper, fuel and lubricant, that's for the generator, computer supplies such as miscellaneous unexpected items, keyboard, mouse, camera for the desktop units. 750, and this would be based on actual expenditures, historical expenditures, incidental tools and supplies, and that could be related to cleaning supplies not provided by janitorial services, supplies for the restrooms, that sort of thing. The 225, and you'll see this across the board for all 5 counties, that's the annual replacement of the battery and pads for the defibrillators, such as the one outside next to the elevator here. Utility charges, what I did for utility, and that includes gas, water, electricity, sewer, garbage. I did a 3% increase across the board for all counties. Typically, I haven't done that in the past, but considering what is happening in our economy currently, I did add 3%. 2,000 is the RICO lease, and you'll see that across the 5 counties. So total operating expense for Benoit County, $122,900.
Quick question. You said, what's the RICO lease?
For copiers,
Oh,
the copiers throughout the buildings, copiers and scanners. So total direct charges of $122,900. We do rent some space to Idaho Department of Labor. Their annual rent is $6,100, and we rent space to Hospice of North Idaho for $3,600 a year.
Christine, sorry to be chiming in, but this is just for Benoit we're doing?
Yes, just for Benoit.
Okay, just for Benoit. Okay.
Yes. So we don't balance the individual counties. That happens several columns later.
Can I ask a quick question about that subleasing of the Department of Labor? If it wasn't being subleased, it would be some other building in Benoit County that they'd be using at a much higher rate, right? Isn't that, you said $6,000 a year? Is that?
Yes. Yes.
I mean, so is there a state set number on that kind of a thing as to how much can be charged?
Speak to that? I believe you did the research
Yeah.
last time.
We did, it was probably two years ago, reached out to a local realty group and got a per square footage idea of what expenses would be to lease that space. And then the actual physical space that Department of Labor is using. We calculated it to come up with that rate. Actually, we got a lot of pushback from the state because they were trying to point at statutes about how state agencies need to play nice together and cut each other breaks, and we held pretty firm to that. I realize that fee doesn't include common space such as bathrooms or lobby space, that type of thing. It really captures the cost of the footprint of the office area that they are utilizing.
Okay.
And basically, aren't they only using several cubicles,
It's
minimal square
What's the
footage?
square footage of that building approximately, too?
I don't have that information on hand.
Is it like 5,000 or 3,000?
It's more than that.
Okay.
It's more than that.
Okay.
The Sandpoint Building, Bonner County, the typical communication costs, phone, postage, internet service. We're anticipating $2,200, and these are allocated costs. Most of these are allocated costs, and we allocate based on the percentage of hours or FTEs to a program. Professional services, that could be, general services. That could be anything related to I'm sorry, I just had a total loss of train of thought. General services. Could be other services other than repair and maintenance services, professional services. It could be something like printing services when we have to send out and have brochures printed for various programs. Some of the rack cards that you see downstairs as you enter in the building would fall under general services.
Like toilet paper, stuff like that. I know.
Yes. Professional services, those are going to be your attorney fees, Bonner County has no allocation for professional services. You'll see those in the general services miscellaneous, general support miscellaneous category, as well as in the individual programs. Repair and maintenance services, that is going to be like your DIVCO for your HVAC maintenance, and the annual inspection of the elevators, the alarm systems, all fall under repair and maintenance. Administrative supplies, again, paper products, any pens, pencils that you might need. Computer supplies, same as before, miscellaneous unexpected items, such as a mouse or camera on your monitor. Specific use supplies, something that, again, that's the AED. Each building has an AED. You'll see that the cost is more in Kootenai County because we have multiple units available throughout the building. Again, our utility charges for Sandpoint, and again, I did the 3% increase across the board. RICO, the copier, for total operating expenses of $53,000 or $54,000 rounded. And we lease space in the Sandpoint building to an entity called Ideal Options. Their rent is $1,700 a month. We have a small amount of personnel cost in the Boundary County for a total of $3,800. Communication costs of $200, general services $1,520. The the repair and maintenance is $13,700. And also in that repair and maintenance, that is also going to include the lawn maintenance and snow removal in addition to HVAC. And it will include the janitorial services as well. Computer supplies, miscellaneous unexpected repair and maintenance supplies, specific use supplies, the AED, utility charges for Boundary County estimated at $10,000. The RICO, copy machines, 2,000. Sandpoint is estimated to have operating expenses of 28,400 for total direct charges of 32,200. Boundary County does not have any lease space. Kootenai County. Salary and wages, fringe benefits of 964,000. That represents about 10, 11 FTEs. That's going to be your administrative staff. Communication costs of $17,000. Employee development costs, that would be trainings that employees attend. General services of $5,800. Repair and maintenance of $100,200. Computer services, $2,300.
Can I ask a quick question on the repair and maintenance?
Yes.
That's related to is there an idea of a completely new roof going on, or is it more of like a patch or?
It would
No.
replace, that's further down.
It's under capital items.
It's a surprisingly large.
Okay, yeah. For the repair and maintenance, then is that anticipating like the next roof, like in 20 years, or what's most of those things?
Well, the repair and maintenance is going to be, again, your DIVCO HVAC system, which is going to be higher in cost than the other buildings simply because of the change in size.
So is that the anticipation of it needing to be serviced or replaced every 15 years or that sort of thing, or?
This is the annual maintenance cost,
Okay.
just the annual maintenance cost for this fiscal year 27.
Okay.
And it's based off the contract amount. We have a contract with DIVCO.
Okay.
And so that is built into this, DIVCO's cost, the janitorial cost, again, the snow removal cost, and lawn care maintenance.
Gotcha.
Although lawn care maintenance is limited. Eric was proactive several years ago, and we terminated the lawn service for this building and purchased a mower, and our maintenance person does the lawn care here. We do have some lawn care maintenance or landscape maintenance, such as spraying for weeds and fertilizing, that sort of thing, but it's limited. So that cost was scaled back a couple of years ago.
Did the finance committee review the salaries of everyone, the staff here?
A lot of them.
Okay, good.
I don't know.
I was just wondering.
I don't think we went into
No, we didn't.
minute detail,
Specific detail, yeah.
but,
We went into program
yeah.
detail and, asked about FTEs.
You know, Kim got a 25% increase in wage.
That'd be really nice.
Is this an announcement? Or is it-
Can we review that again? No, I'm kidding.
Yeah, just like to make a motion.
In the salary component, I think it would be reasonable to say that most employees are under market here.
I mean, it might be good for, as far as all of these finances are concerned, for us to have some feeling for that, or to know at
Yeah.
some point in the future.
I know we spent a lot more time on details on salaries with the clinical because we're in a hiring mode
Right.
and we have to be competitive and bring people in.
Mhm.
Whereas we've got a staff, Jason's got a staff. I mean, put it this way, neither of them came to us and said, we need more money for staff. Is that a fair statement?
As a matter of policy, we do follow the state's pay rates and percent of policy when we set our rates of pay. So we align them with the state.
Is there a statute that requires that, or is that just something we chose to do administratively?
We've chosen to do it because they had a system that was built, and it aligns us with other health districts too, so.
Computer services, and you'll see this in larger amounts when we get to the other program. Computer services mainly represents our contract with Intermax, which provides our internet service. We have an individual on staff 8 hours a day. They're available to us 24 hours a day. They have someone on call, so they manage our network system.
And I'm just going to jump in because there have been questions about, for historical perspective, we did have our own IT staff. And to be candid, it became too expensive to have even one or two staff on. I mean, they can demand such incredible salaries we couldn't keep up. So we did go to a contracted amount. When we changed this last year to Intermax, we went from having 2 folks staffed to 1. So we have seen a reduction in those costs. So we're trying to keep that, we're trying to capture that cost, but IT folks are just in.
Mm-hmm.
I thought AI was gonna put them all out of business.
I think if you're a programmer, that's the case. If you're desktop support, no, we need those folks more than ever.
So we're looking at, for Kootenai County, total travel cost of $2,500, and this relates to any meetings that Eric needs to go to in Boise or any other travel that may be deemed necessary. Administrative supplies, $1,000. Fuels and lubricants, $6,500. Computer supplies, $100. Repair and maintenance supplies, $17,000. Specific use supplies, $475. Insurance, the insurance would be Kootenai County's or the general support component of risk management's fee. It is roughly $65,500 this year. Based on my allocation, it came out to $65,400. It is up about $20,000 compared to last year. The actual premium is $64,170 this year. So I'm a titch high there. Now, hopefully that will come in lower. What they've done historically is they will give you a premium, but if they have excess reserves, it could be less than what they have quoted. But I'm not anticipating that this year based on what's happening at the state level.
Quick question: does risk management? Do they also do our auto insurance and everything? Like
they do
the
everything.
The entire package. Okay.
They do everything. Utility charges for this building, $137,000. Rentals and operating leases, $6,000 for this building. Governmental overhead, what this is, and it's allocated across all programs. The governmental charges represent the statewide cost allocation plan, SWICAP, and that is a cost that the state of Idaho charges us, the district, to utilize their systems, the LUMA system, the state controller, the benefit of the state treasurer's office. And for LUMA, it is based on the number of transactions, the number of warrants issued, line item entries, that sort of thing. And of course, their support for that system.
And a warrant is a check, is that correct? Basically for
Correct.
civilians?
Correct. So total operating expense is $309,500. Here's our big ticket item for the Kootenai building, and I do need to revise this number. This quote was only good for about 15 days, and we received it probably 6 weeks ago, six weeks to maybe 2 months ago.
How many bidders do we get on that?
Right now, we have one that I am aware of.
Mm-hmm.
Sandy is unavailable right now. I suspect she got more, but I need to clarify that with her.
Okay,
And the issue is that flat roofs, people who do membranes, are very, very limited in the community.
So is this like a rolled roof with a membrane applied on top, or is it a unique membrane type roof?
I don't know, I know that it's a membrane type roof and the quote includes repairing potential damage. We were gonna go back and get new updated current quotes
Mhm.
from multiple vendors, but this
Yeah.
was the number that we had, the approximate number we had to work with.
Okay.
And would you like to share the conversation?
Yeah, because Sandy's not here, I reached out to the individual that quoted and they did indicate that the roof is in very, very poor repair.
It always is.
I mean, I know, I'm not naive into thinking that of course the vendor is going to state that.
It's in horrible shape usually.
But I think that it is important that we acknowledge that. And I also think it's important that we get multiple assessments on the roof in order to determine how to proceed.
Yeah, and being that it's such a unique thing, because I'm familiar with that recently, talking about a roof I was responsible for, but a lot of the local people won't do like a pure membrane roof. But some people call a roof that's rolled, that's been coated with a membrane roof, and it's actually different. It's still a rolled roof. So it'd be good to kind of assess that, figure out, do we want another membrane roof or do we want a rolled roof, or, and actually get some competition and expand out to farther in the state, possibly, being that we want also the best person that,
Couldn't agree with you
a
more.
good price. So,
Short of putting a pitch roof on these things.
yeah.
So I think it's important to mention, because the question has been asked several times. We do get multiple quotes, and it's also a requirement as a code of federal regulations, which we have to adhere to when we receive federal funds. So anything within a certain dollar amount, and I don't have that dollar amount available, we do get multiple quotes. Do
So
we
is this-
get responses on that?
So
No.
being that this fits in, so that the federal requirement on that, because we're not a federal agency, so it'd be if we're taking federal money to pay for it. Is that correct?
It is. If you look at the grant contracts that we receive from DHW or any other entity awarding us federal funds, it will state that we must comply with CFR Title II, Part 200, which basically is the Bible for grants management.
Yeah. Thank you. So then with this, is there any infrastructure improvement grants available to kind of offset what we would need to be taking out of our costs as well? Like
I have no
our
idea.
savings? Okay.
And you said Sandy is the one that's working on this, or?
Sandy oversees our facility maintenance. And so,
Oh.
yes, she would be the one calling and getting quotes.
Okay, so there isn't a facilities individual that, like, I mean, like with the county, I'm used to, there's buildings and grounds department who handles that. So, I mean, there's no one here who's buildings and grounds sort of.
No, it's kind of another example. There's a number of folks here that have to wear multiple hats because we don't have the stuff. We do have Dean Johnson, who is basically boots on the ground that does the actual repairs. But when we start getting into the level of reaching out for multiple quotes and spending significant dollars, it moves up to an executive staff level.
Okay.
Okay, it'd be neat in the future with such a large item to, at one of the board meetings, to present, hey, these are all the quotes we got. This is what was considered in them, just because it is such a large
Yes.
item.
Mhm.
Absolutely.
Yeah, thanks.
So total direct charges for Kootenai County, $1,626,000 rounded. We do have roughly $60,000 in revenue that would come in, and that is related to the vital statistic fees, death certificates that are processed here. Shoshone County, communication costs, phones, postage.
Question is, the vital statistics, is that through a contract for the state or the federal government, or is that something?
And it's through the state of Idaho, through Department of Health and Welfare.
Okay.
General services, $600. Repair and maintenance, again, that's going to be there is no HVAC system in Kellogg. That is going to be related to any I need to look at that a little closer. As far as oh, no?
Sorry, Chester's.
They don't need air
Yes,
conditioning. right?
yes. Thank you, Eric. That's going to be janitorial. That's going to be primarily janitorial in Kellogg. Administrative supplies, $250. Computer supplies, $100. Repair and maintenance supplies, $300. Specific use supplies, that's going to be your defibrillator and a rentals and operating. That is going to be the lease agreement in Kellogg. We do not own that building. And
How
there's
long how long have we been leasing that?
probably about Probably about 6 years.
Okay.
That's roughly 6 years.
How's our rate? Is it, like, do we know the price per square foot on that we're getting?
I don't have a price per square foot. The current lease, which became, the current lease goes through, let me look at my note here. The rent escalation is based on the CPIW, and the current lease is $8,668, and it's all inclusive. Utilities, everything, repair and maintenance is included in that. It renews 12/1 of each year, and in this, there's $2,000 worth of Ricoh copier. I do not have the square footage available, but we can provide that to you.
And quick question, I thought I saw that are there no employee FTEs assigned to outside of Bonner and Kootenai? Is that correct?
There was none budgeted this
Okay.
year. There could be a small amount that goes into general support, but that would show up. It's not going to change the total personnel cost in your grand total cost.
Are there any staff there? I thought there was a staff at each one to receive more environmental stuff.
Well, typically what happens is most of the individuals in the outlying office that may be at the front counter
Yeah.
are either doing clinical, environmental, or nutritional services, so they should be coding accordingly.
Oh, okay.
So any general support cost, if there is any, should be very, very minimal.
Okay. And so we don't actually put that in that county to say that that money is someone who's servicing that county specifically.
We have historically, but not
Uh-huh.
knowing what is moving forward this next year without clinic, we did not.
Okay. I was anticipating that we might put clinical people at each location.
Then they should be coding under clinic.
Okay, but not for that county as a sum.
No.
Okay.
This general support services, general support, when people code to general support, they're performing a function that provides services to all district programs, environmental, health promotions, health preparedness, clinical, all programs of the district benefit from their activities.
Yeah.
So if they are only performing for a clinic service,
Uh-huh.
then they have to code to a project number,
Right.
which falls under the clinic program.
That's fair enough. Yeah. Then, quick question: we have the Superfund site too. How many staff are there? Is that one or two, or what's the
There's about 5.
5? And so, but we don't put those in Shoshone.
No, because they're a
call.
separate program. You will
Okay.
see down here, as we get to the other programs, you will see
Gotcha.
salary and wages. And
Okay.
again, they're working specifically for those programs.
Right.
And those activities have no bearing on general support,
Gotcha.
where the district as a whole benefits from their activities.
Okay. Thank you.
Okay, so Shoshone. Total expenditures, $121,300. We also lease space in Kellogg to Ideal Options at $1,700 a month. The next category related to general support is other general support. And the reason why it's called other is it may be an expenditure that is not specifically tied to any one county. Small amount for communication services for employee development costs. And what you will see in here, for example, employee development costs would be related to the all district staff meeting. Historically, the district has an all district staff meeting where employees gather, and there's annually, and there's a training component to that. And also program managers speak to their programs so everyone understands the programs being done within the district.
Is that able to be housed here, or do we have to get another
We
facility?
typically rent a place because
Okay.
our facility is not large enough to accommodate
For
all
the 100.
individuals.
Some.
General services, $1,500. Professional services, this is going to be your legal services. I budgeted $20,000 this year for legal services. Audit, I did budget $40,000 for the audit. The reason why I did that is because Idaho Transparency came out with a requirement that audits need to be within 9 months of the end of your fiscal year, which is a requirement of the CFR. However, we have never been in compliance with that, as well as the other districts have not been in compliance with that, because we have had the LSO, Legislative Service Office, perform our audits. And first priority before they can come to the districts is to start on the state audit. Once they complete the state audit, then they go to the health districts. I'm very happy with the LSO, and typically they charge anywhere from $18,000 up to $24,000. Prior to this latest memo from Transparent Idaho, I had budgeted $24,000 for the LSO audit. Not knowing if there would be penalties involved with Transparent Idaho, I did bump it up to $40,000 if we had to do an outside firm. I think that's a reasonable estimate based on another organization that I'm familiar with. They have to pay an outside firm, and they're about the same size as we are. They have to pay an outside firm for, they pay $34,000, but we also have to have a single audit because of our federal programs. So I threw in an extra $6,000 for that. Repair and maintenance services. This is something that we had previously budgeted but did not complete. Parking lot maintenance, and this is for all 5 counties as needed. If something needs to be done in another county, then they can tap into this $25,000. If you look out front when you leave here today, you'll see a crack in the sidewalk where the walkway is to the far west portion of the parking lot. If you look at that far west portion, you'll see a deep crack there. And I think the parking lots need to be assessed to prevent freeze-thaw damage. Some of those cracks should be filled in and sealed.
And that's concrete, not asphalt? Is that
It's
right?
asphalt.
It's asphalt.
Employee travel costs, this would be the ADSM and related to mileage reimbursement and training costs. Rentals and operating leases, that's going to be the facility that we may need to rent or would rent for the all district staff meeting. Typically, we've been able to get it at a lesser cost. For safety, I did budget $1,000. since we haven't had one in 2 years. Rents may have increased. Also with the ADSM, that involves a portion of recognition for the employees as well, and food cost as well for the event. And we budgeted for 2 base model cross treks, and I believe the idea was one for the overall operation, 2 if clinic continues. Total expenditures for other general support costs, $203,000. We have the potential to receive P card rebates based on using the state P card, which is equivalent to a credit card. I budgeted $200,000, and I always try to budget conservatively on interest. So I did budget based on let's look at my note here. So I estimated that the average LGIP balance for the last 2 years was $7,840,400, and based on my internet research, I found several articles that stated that the interest rate could drop to 3%. So that's basically what I budgeted for interest expense.
A quick question on that. That's income, correct?
Yes, that is treated as income.
Okay. And historically, where has that money gone into the budget?
Right here in interest income.
Like, is it reinvested into LGIP, or is it moved into like a general fund, or what's the historical placing of that?
There's 2 funds. There's the general fund, the 1011 account, and then there is the 2491 account, which is used for board committed funds. So the interest that is accrued in the board committed funds stays in the board committed funds, and then the interest that's accrued here in the general fund stays in the general fund.
And that would be in the LGIP account until it has a better place to move to?
Well, they're both in the LGIP account. The 1011 is basically the operating account. So it just resides in that account.
Okay.
The interest stays there. And any interest earned with the board committed funds stays in that account.
Okay. So it just grows then and will
Yes.
compound unless it's used for some project or?
Correct.
Okay, thank you.
So total we didn't do IT. I apologize. So IT, information technology, relates to our IT services supporting our network. We have $34,500 in salary, and that is a portion of an employee's time that oversees this. We do not have a dedicated employee, full-time equivalent, overseeing IT. We do have someone that coordinates with our Intermax provider and ensures that we have adequate current systems, current softwares, that sort of thing. So that would be a portion of her time
So
coded to the program.
question on that. When we were talking about billing to different programs and different program numbers, is that an amount that goes towards their current salary, or is that an amount that they get additionally for assuming that role, or is it more they build? Let's say if per 100,000 for easy math, then that would be the amount that pays part of the 100,000 that they would get.
It's part of her current salary.
Okay. So there's no billing or code billing to it. It's just that's the amount of her salary.
Well, she
I
would be
guess,
coding if she's working in IT or performing IT related duties.
Okay.
She would be coding the amount of time that she spent to the IT project code.
Okay. And so then that account, depending on how much she actually bills or the person bills, that amount may not all be used or used that year?
Correct.
Okay.
Communication costs, $1,300. Professional services, $81. Repair and maintenance services, 154. Computer services, 16,600, and this would also include additional types of, excuse me, software that might be needed within the district in addition to Intermax. Computer supplies, we've budgeted for some desktop units that need to be replaced to be compatible with Office 365. We have units that are no longer compatible. So the estimate for that is $35,000. The allocated portion of risk management insurance is $200, and the allocated portion for, excuse me, the statewide cost allocation is $200. Total operating costs of $54,000 for a grand total of $88,300 for IT. This blue column is the summary of general support expenses. If we looked at total direct charges, it totals to $2,261,700. We can recover a portion of that, $1,692,000 through the indirect rate, leaving $569,500 in general support costs that need to be either recovered through fees or through county dollars.
Christina, is this, being that it's hot off the press, is this including environmental's new fee schedule? Is this including environmental's new proposed fee schedule, or this adjust in a beneficial direction for us based off the new fee schedule?
The overall budget includes the increase in environmental fees.
Okay. Okay. Thanks.
Okay, so what we'll do next, high level, because the story is the same across the board, with the exception of needed items specific to each program for them to complete their deliverables, the grant deliverables. I'm going to hit the highlights of total personnel, total operating cost, and any capital expenditures. There shouldn't be any for the programs. We'll look at total direct charges and total income.
Quick question. When you say direct charges, can you expand on that term, just so we know what we're talking about?
Anybody who makes a purchase specific to a program would be considered a direct charge to the program.
Thank you.
Administrative programs. Total personnel for this program is $326,000. Operating costs of $136,200 for total direct charges of $461,900. Indirect expense applied of $71,500 for total expenditures of $533,500. We estimate to receive in grant funding $518,500, and also use $15,000 of funds that are currently residing in the restricted fund balance. For total income of $533,500, which matches the expenditures, so no district or county dollars are being applied to this program. I'm leaving clinic for last. Taryn can speak to that program. Health promotions, $239,000 in personnel costs, $153,000 in operating expense, trustee benefits of $4,500 for total direct charges of $396,800. $888. Total expenditures, $446,900. Contracts and grants of $445,865. Small amount of county funds of $1,046. I will also leave EPI. Do you plan to speak to EPI?
I'll speak to the clinical portion of EPI.
Okay,
Is that reasonable?
that's reasonable. EPI. Okay, this is the epidemiology. Aside from clinic, we have the EPI built into the clinic component. So EPI, we have $217,000 related to personnel, $26,500 for operating expenses, for direct charges of $243,500. Applying indirect charges, we have $289,636. With grants, grant revenue received of $192,000. It requires district support of $97,580. The Senior Companion Program, personnel cost of $79,700. Total operating expense of $226,450. Total direct charges of $306,215. Total expenditures after application of indirect of $322,700.
Quick
Grant
question,
funding.
are those charges, is that mostly paying the people that are volunteering, or
Is what?
what are the, what's the 306,000? What's the majority just of those charges going towards? Being some examples.
This is a program that is a significant amount of the cost related to this program is volunteer cost. It's a program where we have volunteers and they're matched with a client where they provide support to that client.
Thank you. No, I'm familiar with the program. I'm just wondering, like the direct charges, is that for reimbursing the actual volunteers?
Yes,
or-
there's $128,000 going
Gotcha,
to
okay.
volunteers and $89,000
No, thank
reimbursed
you,
for
yeah.
the mileage.
Great, thanks.
The award for fiscal year 27 is $291,966, the anticipated award. And we anticipate, and it's quite solid that this will be received, $28,000 in donations. So this program does require a 10% match. And with this $28,000 that is received from an external source, that provides our match. Total cost of the program is $322,700.
Is that external source, is that just a savings account, or what would that be?
It's a donor.
Oh, donor, we have an outside donor. Okay,
Yes.
great, thanks.
Home visiting is next. Total personnel cost, $417,000. Operating expense, $98,800. Application of indirect, $150,700. Total expenditures of $966,000. $245,000 is received in Medicaid fees. The anticipated grant funding is $481,600. County contributions to make it budget neutral of $239,400. Opioid use disorder, substance use disorder. Total personnel costs, $406,400. Operating, $84,600.
Christine, quick question on the health promotions, home visit stuff. Could we get any detail? Kind of like, I think Kim put in, like with some of the other stuff, like or Lisa did with this also with the substance, like how many, some more specs in there, like how many home visits we have and all that kind of stuff.
Kelsey can speak to that.
Okay.
Kelsey, would you like to speak to that now?
Awesome. Oh yeah, the like how many home visits and what conditions and stuff and all that.
Yeah, so in your board packet, there should be from the month of March, there should be for it broken down for each county for how many home visits that we did in each program under Kim's section, but I can break it out further if you would like them broken down more.
I think I saw Kim's section. Sorry.
Under section 2.
Section 2. What page is that?
15.
15. That's right there. Okay. Okay, so that's the total of 62. So then and that's just by that window of time. Okay.
Yeah, each update is, every month we provide the update for each month.
Okay, yeah, and my understanding is that in the mix of things over the last few years is that we have the farther outlying folk that tend to not be served by other home visit programs. Is that correct? So it ends up taking more time and distance and gas and everything, I believe.
Correct. We're the only home visiting program in North Idaho that's unique to the health district.
Okay.
And Dr. Nolan, if I could, that was ultimately the demise of the home health program.
Right.
Which was home visiting in a different capacity. But yeah,
Right,
we ended
yeah.
up with all the outliers and the expenses just made it non-feasible to continue.
Okay.
I think in this case, we do have clients nearing and far because we are the only entity providing those services.
And are we providing, is it more, because it's not like home nursing care.
Correct. So we do primarily prenatal through age 5.
Okay, I got you. That's this program.
So in Nurse Family Partnership, we do first-time moms.
Yes.
So we're supporting from pregnancy through age 2. And then parents as teachers, we're primarily doing kindergarten readiness.
Mhm.
So they don't have to be a first-time mom, but we're serving prenatal through age 5, really promoting literacy, that parent-child interaction, and really teaching them how to interact with their child, play with their child, and really just supporting overall the family well-being and connecting them with community resources.
Cool. And is that a nurse role or an RN role or LPN role or?
So in Nurse Family Partnership, yes, they do have to be an RN.
Okay.
They can have an associate's or a bachelor's degree. And in Parents as Teachers, the program model only requires that they have a high school diploma, but all of our parent educators through the health district have a bachelor's degree.
And I think this was one of the programs that Director Adams of Health and Welfare, when he was there, was very supportive of, because a big component of this is keeping families together, children with families in higher risk situations,
Mm-hmm.
and preventing, overuse of the foster care system, which is much more expensive.
Mm-hmm.
So that is a goal or the intent of this program.
Yeah, absolutely.
Operating expenses, I may have already addressed this, but 98,800. After application of indirect, 150,700 for a total expenditure cost of 966,000. Medicaid revenues of 245,000 and grant funding of 481,600. We did go over this, I apologize. County funding of $239,400. Opioid use, total personnel cost of 406,000. Total operating expense, 84,600. 64,000 in trustee benefits. Total direct charges, 555,000. 640,600 total after the indirect is applied. And We anticipate using the opioid settlement funds of $631,755. And actually, that can be built into the revenue. So, we would have then $0 in county support. Nutrition services, $943,200 in total personnel cost, $100,000 operating cost. After indirect is applied, $1.2 million in total expenditures. Revenues of $51,300 in fees received and $740,985 in grant funding, applying county dollars of $428,000, balances the nutrition service program.
Quick question on that, because that manages the WIC aspect of things, is that correct? And so does that amount include the pass-through of WIC funds that we're administrating per se? Or is that a different account that would go directly?
The majority of the $740,000 is the WIC funding, the grant funding.
Okay, so it's in and out basically, minus the administrative fee.
Yes, in and out, we have the funds coming in, and up above, we have the expenditures related to those funds.
Do we need to have that spent first and then we get reimbursed, or do we get funded at the beginning of a time period for the
No.
amount anticipated?
No, it's a cost reimbursement grant.
Okay.
Most of our grants are cost reimbursement.
So just so I know, when a person in need goes to the grocery store, say Super One, and buys something on the WIC program, does the grocery store come and ask us for that money? And then
No, they're issued vouchers or Kim, could you better address that, please?
thanks.
Sure. So what happens is when they come to us, the funding that we receive is really to administer the program.
Mhm.
The funding at the store, that's going largely through our state or USDA
It goes
and
straight to the
rebates.
store.
Mhm,
Okay.
correct.
So this is just our administrative funds. Okay. Thank you.
Correct.
Yeah,
Mhm.
thanks.
So the total public health services programs total $4,893,000. Total operating expense of $1.3 million. Capital expenditures, this is related to clinic. Taryn can speak to that. So total expenditures of $7,300,000 with estimated revenues including county support of $6,871,000. Remember, these totals include what Taryn will be speaking to shortly. Looking at environmental health, total personnel cost of $2,325,000. Total operating expense of $278,800. Trustee benefit payment of $12,000. After indirect, total expenditures of $3,098,000. Fees, and this includes the fee increase that Jason just presented. Fees, $2,193,000. Grant funding of $582,700. District support of $322,564. Brings the balance or the budget into balance. Public health preparedness, $341,000 in total personnel cost, $38,400 total operating expense. After application of indirect cost, total expense is $451,600. The grant is $410,000. This grant requires a 10% match. ICP, the Institutional Controls Program in Kellogg, which oversees the Superfund site, Total personnel cost, $593,000. $143,400 in operating costs. Trustee benefit payments of $13,000. Application of indirect brings total expenditures to $871,000. Their grant, $871,000. They fully pay for themselves. One thing that we had mentioned in an earlier meeting is the cost of health insurance. I had previously presented to you that the health insurance would be $17,770. And the governor recommended that the cost of health insurance be reduced to $16,170 per full FTE. So that was a $1,600 savings per employee. So that was positive. And this budget, as it's currently built, represents approximately 95.78 FTEs compared to 94.99 the prior year. If no one has any questions, I will turn it over to Taryn, and she can address the clinic budget.
Yeah, I have a quick question, but this could be for Taryn too. Does this include the new MP hire for prospects?
Yes, so it includes the new or an additional nurse practitioner, so a total of 3 nurse practitioners, a full-time physician, and a medical director, and
we
then a couple of other staff as well.
Great. And we currently have 1, and we're hiring in a second, and we're
Yes.
hoping to hire a 3rd. Is that correct?
Yes, our second nurse practitioner will start at the end of this month.
Mhm.
So we'll have 2 full-time nurse practitioners, and then we are going to be actively looking for another nurse practitioner as well.
Great.
Yep. And I think we're going to hold off on searching for a physician right now until later in the year. We budgeted for 6 months.
I need to correct myself. Last year, we had 91.99 FTEs compared to the 95.78. So it's a 3.78 increase in the fiscal year 27 budget,
Is that primarily for clinic or no, others too?
primarily related to clinic.
Okay, so starting with sale of services. This 1.3 million is a rough guesstimate based off of Dr. Pennock's calculations. So his thought process is using fiscal year 25's income and then dividing it by 2 because we had 2 full-time nurse practitioners and multiplying it by 3 to factor in that 3rd nurse practitioner. We also added an additional $200,000 anticipating revenue coming in from the physician of 6 months of their time. So this is a very flexible number. This was just the best guess that we could get based off of historical data because things are going to be changing and there's going to be possible shifts in how we bill, how we charge, what services we provide. Other income that we are anticipating is the same grants that we currently are utilizing. So our immunizations grant, our Title V family planning grant, and our women's health check grant. Miscellaneous revenue, $1,100 in here. If we order a bunch of flu immunizations, we don't use them, we send it back, we get some credit back from that.
Is that what part? Do we have partial credit or is it like restocking
It's
fee?
partial credit, yeah. We try to order what we think we're going to use, but sometimes it doesn't happen. Gross salary and wages. So we are sitting at about 1.3 million. So this is with the addition of those staff that I just mentioned, plus all of our current staff that are currently on board, and an additional nurse, an additional billing representative, and medical assistant, and a PIO. So
And we're doing billing in-house, is that correct?
that's correct. Yes.
So we're
we
not
have-
having to pay a bounty to an outside biller.
We have one full-time biller and then we have one part-time who's also working as an administrative assistant in the clinic as well.
Okay. Thanks.
So what is also included in here is moving expenses and a hiring bonus. This was at the request of Dr. Pennock, and a 2% salary increase.
What was the last thing? The salary increase? What kind?
The 2% salary
The 2%,
increase
yeah.
rather than the 3%, which
Okay.
is typically what we do. Right?
Based off the state. Yeah, the austerity. It's kind of.
All right, and then combined salary and fringe benefits, 626,000. So again, total increase or in health insurance, everything like that combined into one number with the addition of those additional staff. So total salary and fringe, we're looking at about 1.96, which is a significant increase from last year, but with the addition of 2 positions and an additional nurse practitioner. So
Question. So when you indicated the revenue, and that was anticipating the potential increased billings with the new staff?
it was. So we only, what we did was we multiplied it out from the two nurse practitioners in FY26. Then multiplied it by 3 to anticipate the third nurse practitioner, and then added on only $200,000 for the physician. And Dr. Pennock said it was a fairly conservative guess at what revenues could be, but it was some number based off of historical data, essentially.
You mean the income per practitioner?
Yes.
Okay.
Yes, so
And
our
you-
fees
and you
for
estimate
service.
that to be how much?
It was 1.3, I want to say.
Can
Yes.
you correlate that to the number of visits that, what is the amount of visits that you think are
Off
going
the
to
top
be
of-
seen?
Off the top of my head, I'm not sure what the visit totals would be. I anticipate we're going to be seeing a whole lot more visits with this current staff than we were in 2025.
Do you
I think I can address some of this using historical data, not imaginary data. The way Dr. Pennock reasons the numbers in this context is the nurse practitioner will have salary and benefits $150,000 and will generate $350,000 in billings collected. That's even using the collection ratio. So each nurse practitioner is actually a revenue source of $200,000. So he's imagining running the clinic the way he ran his own medical practice, or I ran mine, or you run yours. We're not broke. Actually, you can make a living. You can make a really good living in the practice of medicine. So if Panhandle Health can imagine running a full real clinic, then it's money generating. So these scary numbers look scary because the default assumption in a bureaucracy, a state bureaucracy, is that employees are black holes. No, they don't have to be black holes. They can actually be producing lively, contributory human beings. They're actually adding to society.
All the rest of you guys are pretty awesome too. But
Well,
What I was thinking was that, roughly there's 250 days of work if you work full-time for a practitioner. And so, for $250,000 income, you're just kind of only anticipating that you're bringing $100 a day.
Right. And like I said, it's a very conservative
Yeah,
estimate.
it's very,
We might not be
very
able to hire a third nurse practitioner for another 6 months. So that's going to affect how much revenue we generate as well.
also, as I was
well, he
speaking with,
actually has several that he's
Yes.
working on. I mean,
yeah,
But my point is that, that's really conservative because chances are a practitioner is bring in more than $100 a day.
Absolutely. Yeah.
and then I was speaking with Eric and Christine that we could look at a kind of a formula on ramp up because they're not going to be bringing in full scale at the first month. but like 3 months, 6 months, 9, 12 months anticipated revenue, so we can look at what would be the true cost over the year to assess that, and then we can know, okay, that's the actual amount that we
And
have to
with the
fund.
dual clinic models tool too, that's also going to shift what our revenue is going to look like because it's not going to be the traditional revenue that we're projecting this based off of.
So just go back to where I think you were at
Oh, yeah.
the total salary, I think.
Oh, this was our
Anticipated?
revenue. I can scroll down to
Yeah.
the salary.
Thank you.
Oh, did I pass it? No, sorry. So this is going to be our total salary and fringe down here.
So that's where I'm trying to understand why would that be more than the other one, being that the nurse practitioner is currently bringing in 200 over her costs about, and if we're anticipating three similars, then they would all be. So then, where are the most of the costs? I guess because, and also I know that I think the LPN is also covering a lot of their costs through stuff. So I'm just wondering, why is that number so much like 300,000 ish more than the revenue anticipated?
Well, I mean, just with the actual cost of those physicians and other staff that are coming in. So also the medical assistant, the other billing person. That's just the math, how it shaked out to be. The revenue side of things, we can't necessarily anticipate it as accurately as we can for staff costs.
So I'm thinking that but all staff thought to be brought on board will be bringing in more than they're costing,
Ideally.
And MA should definitely help the clinic make more money than if they weren't there, for sure, if they're being effective. So,
Let me
yeah.
make a comment here. Thinking globally, we know that the current clinic system is barely existing. If we do nothing, we might as well shut it down. But if this group is going to decide to move forward, then we're going to have to make some bold decisions, admittedly. Now, there are three ways in which we can justify these costs. The first is the Panhandle Health has enough revenue in the bank that is free and clear of restrictions that we can cover these costs without going and asking these guys for more money. That's number one. And in fact, my goal is not to ask them for a penny more money. Okay? Number two, we can anticipate that in time, the clinic will be self-sufficient. In fact, in time, it'll make money. But it is a true statement, and this is what I tried to say to Tanya Wilson when she asked this question at the last board meeting. We're going to have to bootstrap ourselves into existence, and it is a gamble. I mean, I would be a fool to tell you, oh, this is a certain deal. If you build it, will they come? Well, maybe they won't come.
No, Thomas, I understand that. You have a good point. My thought is just in the numbers, because we don't have, in a clinic, you have to pay rent and things. We don't get charged rent per se, do we?
No.
The Panhandle proper doesn't charge the clinical program rent, right?
Right.
So I'm just wondering, if, like, where's that 300,000, something, $330,000?
I would like to also point out that Dr. Pennock did come up with these numbers.
Okay,
I'm just the
okay.
messenger here.
You're doing great. You're doing great.
So I would encourage you to ask him.
All right, we'll look into it. But
No responsibility.
Thank you, Taryn.
I would love to give you a better answer, but that's kind of.
It's a question to investigate. We will.
Right.
Yeah.
Yeah, I have a question, and I'm not sure how long you've been in your position, but just historically, because Panhandle has had, I know, a lot of turnover of nurse practitioners, probably the last 9 years, but for sure 5 years. And so historically, when a new clinician comes on board, there's a huge credentialing curve that you have to get through before you're actually generating any insurance billing. So historically, as we have seen turnover with clinicians, how long, so to speak, before they're fully trained up and holding on to full billable schedules?
Well, a huge piece of it too is the individual themselves, how fast they're able to pick up certain things, how fast they are actually being trained in the clinic, and that's just up to the individual. But as far as credentialing, it's up to the insurance company. Some of them can take 6 months for us to be credentialed. I think Medicaid is the hardest one. Some of them, it's like a 2-3 week turnaround. So they kind of trickle in as time goes on until they're fully credentialed. But I would say generally it's about 6 months before they have everything.
So my question along with all those questions is when the numbers were created to come up with what we think we're going to take in, did we take all of that into account? Is there a way is there any hard data, any, structure to, like a plan? I just know, like, when I work at the hospital, if we were going to put a new service line in, we had a form that was called like a performa or something like that. We know that when staff come on, they immediately do not have full schedules.
Right.
And it is very staff dependent.
Yep.
I mean, some people are going to pick up the full schedule much quicker than other people. So I'm just trying to understand the whole, and maybe.
Well,
Peggy, I think we're saying the same thing. Exactly. That's what I was wanting to do, is that formula I was talking about that would basically be that performa kind of ramp up towards, I would say rarely is do you get a staff member getting at full scale prior to a year. Right. So more like 16 to 18 months. But if they can be at full at a year, that's like a hot performer. But so the idea is though, is that we would have that calculation anticipating those revenues as we think that would be realistic for them to come in. That would offset then their costs so that we know what's the true cost over a year. It's not the actual cost of their salaries and benefits. That's the cost minus what we think they'll be ramping up to until they're at full. I think it'd be a good idea to do at least an estimate on that.
And with the credentialing too, it's not like they're not going to be seeing a full caseload if they're not credentialed with certain insurance companies. We're just going to schedule certain people with that provider. So that's kind of where our clerical staff comes into play and screening those patients for insurance and then putting them on that specific provider's schedule based on that too. Yeah.
Commissioner Corn.
Well, I just had a quick question. Did I hear correctly that each nurse practitioner is going to generate roughly $200,000 a year?
That's what the calculation is based on, yes.
And I heard Dr. Duke there say it's about 250 work days a year. I think that math comes out to just under $1,000 a day, not $100 a day. Right?
And that's about right, actually.
Okay.
They can do
Just
that.
wanted to clarify that.
Order of magnitude.
I'm like, $100 a day, I'm signing me up as a business, and we're gonna be rich. But we have to
Right.
generate about $1,000 a day to get that projected number.
Correct.
Okay, thank you.
Oh, yeah, my bad. Sorry.
Any other questions before we move on to expenses? Okay. All right, communication costs. A lot of this is allocated just based on the number of FTEs that we have, but that equals out to about $14,000. Employee development costs. So Clinical Up to Date, that is a platform that our nurse practitioners use for their patient care. $5,500 for annual trainings, and that's an overestimate.
Do we fund CEs for any of these people or no? As part of the package?
I'm sorry, do we fund what?
Continuing education as part of the package?
Yes, so Caitlin always likes to go to a family medicine conference every year, and that's dependent on if we have it in the budget, if there's one available. Sometimes it happens, sometimes not, and we are very clear with our providers about that, but if there is an opportunity, we have the money, we'd love to send them. General services, so $7,200 for our PharmaWatch monitoring for all of our lab units or lab refrigeration units for our vaccines. $12,000 for CDD lab services, so any samples that we send off-site. That comes out to $19,000. Professional services. So LSO audit is $4,000, and that's again just one of those allocations. $10,000 for legal services and legal advice for the dual clinic model. $1,300 for Boostlingo, that is our translation services. $20,000 here. So anticipating every Thursday with our Kootenai Health Medical Residency programs. So in the past, we would do it and they would charge us $1,500 per day with a physician and residents. Dr. Pennock is going to be negotiating that contract. So I brought it down to $20,000 just in case contract negotiations aren't successful or whatever happens with that. So that $20,000 is a conservative estimate. $4,000 in promotion and publicity. With this new clinic reshaping, remodel, I would like a little bit of a budget to be able to advertise our services and bring clients in. Other professional services. So $70,000 is dropped into this bucket. This is in case we need the services of a recruiting professional. So with hiring these professional physicians, the nurse practitioners and the physician, we don't have a whole lot in North Idaho to choose from. So we are most likely going to need to have the help to bring in someone from another state. These fees are based on 12 or 15% of the starting salary of the nurse practitioner or 12% of the starting salary of the medical or the physician. So this is, we most likely will not be using this entire $70,000. We just hired on a nurse practitioner that was not included into this. So this is for 3 positions. Building repair and maintenance, allocation $8,000. Office equipment, $2,000. That would be the RICO lease. Printing services, paper marketing, flyers, brochures.
Good question. Is that every time we say Rico, is that like one machine and is 2,000 or what's the 2,000?
It's the brand of the machine that we rent.
No, I know.
Yeah.
But is that 2,000 like one machine?
I think it's per unit, right?
So every 2,000 you see up there is one machine?
No.
Oh.
Several departments have multiple units, so it would be representative of the number of units.
Okay. Great. Thank you.
Computer services. This is going to be our EHR, our billing claims platform, and our IT services. So a total of $55,000. And those costs are also broken out over here. All right, travel costs are travel in between clinics for serving those other communities. Family medical conference, this is also put down here just in case there is flights out of state and lodging out of state. $1,000 here for out of state travel, recruiting expenses if a staff member is going to be recruiting staff in another state. $2,000 in office supplies. $12,000 in gasoline. We are anticipating a whole lot more travel in between those outer offices with more staff. $800 in peripheral equipment. We need to purchase a new printer or 2 new printers. Specific use supplies. So $27,000 for birth control. $20,000 of that is our Nexplanon devices, and that is based on 340B pricing, which is grant dependent. So if we do not accept a grant, we are not able to use that pricing, so that will get a lot more expensive. Medical and lab supplies. This is supplies for the clinic.
So is that mostly IUDs or is that also oral contraceptives?
All oral contraceptives is also lumped into that as well.
Okay, so both.
Those are the big ticket items, those
Okay.
the devices.
The devices are, when you say devices, you mean IUDs? Or?
I mean IUDs and Nexplanons, so
Nexplanons,
anything that
okay.
is like inserted essentially.
Gotcha. Yeah.
$160,000 for for vaccines in total. This number, the annualized, is not accurate because we purchased way more in the fall than we do in the spring. Other specific use supplies, $400. And then $2,600 in here is for specific use supplies. So in total, specific use is $213,000. Insurance, based on an allocation, $12,000. Copier leasing, printer rental, offsite record storage, because we have to maintain record storage for a number of years. Miscellaneous expenditures, when we have a person that pays for their service and credit card, we accrue credit card fees, so that's $3,500. Governmental overhead, $10,000. $4,000 in recruitment expenses, and that's per Dr. Pennock's request as well.
Quick question, the records, is that from legacy charts, like paper charts or?
Yeah, paper charts that we've like put into, or we haven't put them into
Digital.
form, but we have to still retain them if that person requests.
What was the cost of that again?
$700
A
renting.
year? Or a
Yeah.
month? Yeah.
Yeah, per year. Other miscellaneous expenses, so $1,400 for our licensing for the Board of Pharmacy. So total operating expenditures is almost $500,000, so $487,000. Other equipment, I budgeted $8,000 for a autoclave repair or replacement. We have one for 5 counties right now. We might be able to repair it. If not, I budgeted to replace it.
So are dirty things transported back home then, or how does that work?
They have to be transported back to here, yes, because we only have one for all 5.
Okay.
So total expenditures, $2.4 million. Operating in a deficit of 1.2. Any questions?
Good job, thanks. How does that compare to the last couple of years, the deficit?
Well, if you look at fiscal year to date, the actual deficit for fiscal year 25 is $661,000. Compared to anticipated fiscal year 27, $1,253,000. The double, fiscal 25, 27. And fiscal year 26 annualized, because the fiscal year to date actual was as of 12/31. So annualized, we're estimating that and will end in a deficit of $676,000. Very similar to the actual for fiscal year 25. So it's kind of double.
Now, my goal here is when we go to the commissioners, will be to ask them to as well run an experiment. We're all running an experiment. But the conditions of the experiment are that we will not ask them for a single penny in addition for contribution to the clinical services. But in lieu of not having to pay any more money, we're going to double the amount of time, face time, clinic time in their counties. So they will spend no more money, but they're going to get double the services. Now you say, how can we make this happen? Well, we make it happen by one of 3 mechanisms, or all 3 mechanisms. The first is we have the money in the bank. We can make our own investment, and we don't have to ask the commissioners for a penny. So if we're going to make an experiment here, I think it behooves us to pony up. Don't ask them to run our experiment. That's number 1. Number 2, we hope this doggone thing makes money someday. So, and then number 3, and here's where it gets a little dicey, but you understand out of the $2.2 million that those guys give to us, some of it is in fact has strings attached. For instance, the food handlers program. I mean, they have to subsidize that. There's state statutes. Moreover, the state even mandates that they spend like $1.2 million or something like that. In other words, they have to spend a certain amount of money because the governor tells them to. And then also we have to have food handling. So some of this is outside of our jurisdiction of control. But at least $1 million of the money that they contribute to us is fully discretionary. And they can say, well, look, I prefer that program, not that program. So we're going to have a detailed conversation with the commissioners as to how they want to spend the money. And that's the, shall we say, honest conversation that I intend to have with the commissioners. So these are scary numbers. Yes, we know we're going to running an experiment. Yes,
I don't think it's fair.
but we can. It can happen with the appropriate will, the appropriate skill set.
The numbers are conservative. Yeah.
Actually, I'd like to hear from our commissioners. Commissioner Cowell, are you there still? Melissa? Did we lose her?
Yes, I'm
Oh.
here.
Do you have any questions or comments? I mean, you're going to be voting on this. I'm real interested in your opinion.
Well, most commissioners, our opinion is, well, how much is it going to cost us? So,
Right. But you heard me say we're
yep.
not going to ask you for a penny more.
Yeah, exactly. But that's usually just the bottom line with, the county commissioners.
As it should be.
Exactly.
Right. Commissioner Korn?
So I think I made a statement last month regarding this. And when you and Dr. Pinnock came to the county and gave us that presentation, I was kind of set back, realizing and seeing the numbers that the amount of people that you provide in our county services was only like 500. I think it was 524, if I remember correctly, out of 50,000 residents. So it was a very small percentage of the people, of our citizens that are using the PhD services, that we are collecting taxes from all 50,000 of those people to help pay for 500 people. I don't think that's very fair, in my opinion, very responsible. And I don't mind having some buy-in to your guys' vision here. I hope it works. But I'm also going to say, as I said last month, I don't want to dangle this over your head, but I would really like to see the informed consent come into play. Mm-hmm. Otherwise, for me and for a lot of the people that I represent, it's really a no-go. Mm-hmm. So that's where I'm coming from. I don't know where the other two commissioners stand as far as Bonner County goes, but I would like to see some further action from Panhandle Health that I can't get anywhere else.
Mm-hmm. Well, thank you for those comments. Mm-hmm. Are you going to be here when we discuss the next agenda item? Please stay around because your remarks are cogent. And thank you for saying them. In other words, if I understand you correctly, you're fiscally conservative. You have a responsibility for the stewardship of the taxpayers' money. You're not seeing a whole lot of bang for the buck coming out of the Panhandle Health clinics. Now, you're willing to move forward on the condition that there is a qualitatively different moral position that the public health clinics take vis-a-vis the private health clinics. In other words, you want to see genuine informed consent. Is that what have I put words in your mouth?
That's what I said, but I said it in layman's terms.
That's why you're a commissioner. You relate to the people. I'm kind of a nerd. I've always was a nerd. I couldn't even get a date with the girls in high school. All right. Any comments, questions? Peggy, you must have some.
No, I need to break.
Oh, okay, fair enough. I know He's got to go.
I gotta go.
Then I'll tell you what, this has been long. Thank you, both of you. I'm going to look for a motion
And the motion in
is to
relation
accept,
to,
is to accept the budget.
I'd like to move that we accept the budget.
Do I hear a second?
I'll second that.
Well, I guess, well, we have Melissa. Actually, we could do a roll call vote, but in all due fairness, we ought to wait until she returns.
This is the not, as you would say, Christine, I think, the not balanced budget. Is that correct?
Thousand,
Mhm.
where that funding source is going to come from.
Yep.
And then also, but that's it.
Okay.
The other item was, we just need to get a tighter estimate on the
Right.
roof.
Okay,
You wanna-
so I'd like to make a movement that we accept this budget with, balancing it with, transfer of uncommitted funds that we have reserved.
I second that.
Well, I suppose we could begin the roll call vote. We won't finish it until Peggy returns, but we can at least get 4 of them.
Any discussion?
Any discussion?
And Chairman, just if I may, we do have those funds in reserve, but I think Dr. Nolan has expressed it, that if the goal is to be budget neutral with clinic, we can't, there's only so much reserves we can pull out over time to be able to augment the deficit.
I agree.
So I do have concerns. I would certainly like to see clear demarcation on how we're going to get there over time.
Correct. So you don't want an ongoing hemorrhage.
Yeah.
You want a quick clot or a Israeli bandage on that thing.
We clearly see that we're making progress in the right direction so that we're being responsible for the taxpayers' money to.
Yeah, sure. And that's where I think probably need to have a conversation with Taryn and Dr. Pinnock about the details of the numbers and figuring out, okay, really nuancing that a little bit more. Because I think that gap could probably be closed. And if we don't end up hiring another MP this year, then that extra money is not being spent either. So it would be able to be roll over.
And as time unfolds as a board, we can always say, okay, this isn't working, we can stop, so that's not a concern.
Yeah, I
Right.
just surely welcome those
Yeah.
conversations on what those metrics are going to look like.
For sure. I think it's wonderful.
Peggy, we waited until you returned. There's a motion and a second, but we have not voted.
We'll discuss.
Or discuss. Do you want to discuss the budget anymore?
So the motion, I believe,
Is to accept the budget with the, to balance it with transfer of funds that are uncommitted and reserved.
And what was the dollar amount of that?
$428,630.
And I know Christine had mentioned previously during one of our finance meetings, there was just a concern where if we don't recoup those funds, is that a valid point or not a valid point?
Well, it is a valid point. My concern is investing significant dollars that we currently have in our general fund or in our board committed funds. And the inability to recoup those funds in the future. I think we also need to look forward in the event that clinic is not successful. I think we need to look at both the positive and the negative.
Oh,
I think
absolutely.
part of that
Okay.
would be assessing different target points and seeing if we're making those target points.
They need
And
to
all
be,
of that.
excuse me, I didn't mean to interrupt.
You're good.
I believe.
So
we
what
need-
you're saying is if it doesn't work, it doesn't work. And we should be
No, I think you're
mindful
saying,
of that.
yeah, Dr. Fletcher, I think she was about to say,
We need a business plan with clear benchmarks
yes.
and when to recognize that if it should happen, when to recognize that the clinic is not going to be able to sustain itself and know when to call it, draw the line in the sand.
Yes. I think that's a wonderful thing to do.
And do we have that? Do we have a business plan with clear benchmarks?
Depends, probably maybe not on some people's standards and yes on some people's standards. So kind of.
Well, in some manner, the answer to your question is that budget. A lot of those numbers are in fact the pro forma.
So I think part of it is the business plan is hiring more people, knowing that there's, thousands and thousands of people in North Idaho and the Panhandle region that are waiting many months or can't find a provider, or a provider decided to shift over to another thing, or their provider went concierge and they can't afford the provider, and all of that. So basically, the need, the patient population need is established, and so the idea is you get the people there, and we'll start to fulfill the need for the people that can't get their care otherwise elsewhere. Plus, we'll be able to then ideally service your county and the other outlying counties more regularly, so that hopefully they'll get better care and more screening and all that kind of stuff too. I think that's the idea. So, do we have a detailed business plan that would make an MBA happy? Probably not. But I think as far as marketing, we discussed marketing. So that's something that we're going to be developing a little bit more, as well as an appropriate marketing strategy as well. Because partly you have to let people know you're there. That's the biggest rule in business. People have to know you're there, even if you're a government business. So,
If I may, in that business plan, would it not be unreasonable to expect certain benchmarks at certain periods of time?
very reasonable.
Absolutely.
That's actually what also kind of part of what Peggy and I were talking about anticipating revenue growth, as well as when should that happen by, based off of knowing that on the long end, it's about 6 months for some of the, if you're going the insurance route. If you're not going the insurance route, well, then you can start making revenue day one kind of thing. Probably not day one because your schedule may not be full, but within a month or two being there, you'll start to get money trickling in. That's fee for service, assuming that the CMS lawyers and all that stuff get that figured out. So.
So then will it,
Well, another important point is there are physicians involved who've done this many times. Started practices and understand the costs and the income
So
potential.
with that, we need to write it down.
Agreed.
my point.
Yeah.
That is my point. And my other question is, will the board be expecting Dr. Pennock to develop this plan?
Yes.
Okay.
In conjunction with the medical subcommittee.
Yes,
It's not going to be solitary.
Mhm.
yes, okay.
So the other question I have about funding and the budget would be related to because I know we don't have legal review yet of this new billing model that we're.
Hopefully
projecting.
shortly. Hopefully in the next month, maybe.
But does it put any of our grants at risk depending on the information that we find out?
Potentially. But we have, there are grants that put us in the hole. So some grants, not all grants are a blessing.
So I understand, a firm plan, but I feel like there's a little bit of, uncertainty and
There is.
not clear. I know we'd all like to have a crystal ball and see the future.
Yeah, no, there's definitely some uncertainty, but I would say with educated thought process and experience, then the chance of it failing is lower than it would be otherwise. But I can't say it's not zero for sure.
Well, we have any other discussion?
I have a question. So your motion is basically, you are approving to take this budget out to the counties.
Well, after we've done the in-house reallocation of funds so that we don't have that glaringly red number, we would like to at least present to the commissioners that we're not begging for that amount of money. I want to make clear to the commissioners, we're not asking for 1 penny more.
So that amount will be adjusted to come from reserves.
Correct.
And my question also is, when I was discussing general support, I stated that the roof liner, we need a better estimate for that. So we're comfortable
much.
with,
Well, you had a big number in there for that.
Well, I am not at this moment comfortable with going with that one quote. I think we definitely need to review that and look
oh,
at
absolutely.
and get a list of all of the quotes that came in, and then see, do we need to expand from there or not? But I think as a number, you have to start with somewhere. It's the only number we currently have, but it doesn't mean that we have to actually go to that. Is that
So we
correct?
all recognize that that is an estimate and subject to change.
Yes,
Correct.
for sure.
Mhm.
Yeah, that's a good point.
Any other discussion? Hearing none, roll call vote.
Just a heads up, it looks like we lost Commissioner Cowles during this conversation, so she logged out. Peggy Cavallo,
Yes.
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Chairman Fletcher.
Yes. Okay, next agenda item is a report from the medical director. Now, it happens that Greg is with his children and grandchildren. We could hear from Dr. Nolan. Now, the hour is late, Dr. Nolan.
Yes.
Um,
I'm going to keep it extremely short because, I mean, we've been talking about medical stuff this whole time. But I just wanted to highlight that it's exciting that we made a hire for an MP. So great job, you guys, working through that. Other than that, we're going to be in the process of, as we've been talking about, developing a more concrete written business plan and how best to be a wonderful steward of the finances that are available currently. So.
And Dr. Nolan's being humble here. He's actually put together a lot of thoughts on how to move forward with this clinic. So there is some thinking going on in the background, Christine. It's going to happen. Is that it?
I'm done.
Okay.
Yeah.
Next item is the second reading on the health bylaws. Everyone's had now a couple of months to look at the language. Peggy?
So at our last meeting, several board members recommended that we have legal review of that document.
Uh-huh.
Has that been done?
Well, it was no motion, and I can't, in fact, we can't engage legal without a specific board motion, second, pass, and a budget. And so that wasn't done. In fact, it wasn't even an action item. It was discussed, but I would ask, what about that language needs legal review? 95% of the language is already bylaws. There are really only two changes, and they don't change, if you will, well, I don't know. They change what they change, but the document is 95% already existing language. So what blessing, legal blessing, are you looking for?
Well, I know that, and Commissioner Korn, you'll have to bear with me because you and I may respectfully agree to disagree. But, my first meeting on this board, the issue of the informed consent came up. And we had a full room with people both for and against. And there were several opinions by attorneys regarding informed consent at that time. In fact, Dr. Fletcher, I actually remember you saying at a meeting that you would never have informed consent. You personally would never put informed consent on the agenda. The last meeting, I felt there were like 3 board members that felt that needed legal review. And I still feel strongly that needs legal review. So I myself will have to recuse myself from any action.
Which board members felt it needed legal review?
Well, I know Tim and I know myself.
And I don't
That's
think there was a third.
I had notes that you had also agreed with that, but it was only notes I had. I'd have to go
Okay.
back and watch. I'd have to go back. and
Well,
watch.
so my thought on that is if you could express, 'cause I know that you have deep founded concern about it, could you express what your concern about the concept, either the concept of informed consent or, and if you could just let me know through our conversation, it was also more of you were concerned that it would be abused somehow. Is that true? And you can take those words back and say, that's not my words, but I'm just trying to
No, I
draw
don't
you
think
out.
those were my words.
No, good. I'm trying to draw you out so that you could then express what are your actual concerns with it, so then we can understand better where you're
Well,
at.
I would really like to understand what informed consent means, because when it was first presented at this board, my very first meeting, the information, and again, this is my personal opinion, I only have 30+ years in Wood County and working in all the counties in Wood County. And, doing disease investigation where children had died from vaccine-preventable diseases where vaccines were not available at that time. At that meeting, the information presented as informed consent, this is my opinion,
Yeah, that's good.
looked as if it was somewhat biased about the use of vaccinations.
Mhm.
So I need to understand clearly what the terminology informed consent means when it comes up. Does it mean the same thing that it meant last February? Or
Can
does
you-
it mean something different?
Can you give me an
You- you-
example of last
well-
February? I wasn't part of the board at that point.
I could share the packet with you, but I don't have it with me.
Was there a certain concept that was the concern? Because, I mean, I can give you an example of informed consent it's not a signing of a document. It's a ongoing discussion and presentation between any provider, not just physicians, but any provider and the patient.
Which is what legal.
When a patient has the legal ability to make that decision. So for minors, it's with the parent, and ultimately the parent then can make the decision. And so for adults, it's with the individual adults, unless there's a caretaker that has court, custody. So then, and the idea is that you are to give all of the pros, the cons, what's known and what's not known, and the options of doing the therapy, the options of not doing the therapy, and then any other alternative option. And so that's like what informed consent is in any institution, any hospital, whether or not it's done, that's actually what it is. So based off of that comment, because it's good to define terms, is I think partly you wanting to define terms, which I think is really important. So say if that's my terms, do you agree with that or disagree with that? Or are there parts of it you don't? And that's any of those are fine.
I agree with that concept,
Mm-hmm.
but from my history as a board member and what had been presented as informed consent,
Mm-hmm.
Your concept and what was presented were two different things.
Potentially.
If I may make a comment, Peggy, is that the comments that were made from the public that day where it did not match what we had presented. We had some information from government organizations that just laid out risks that were potentially involved that were not part of the informed consent sheet downstairs. The informed consent sheet downstairs concerning COVID-19 was that there was a rare occurrence only of myocarditis among young men, which seemed to be temporary and very rare. That was the only negative, except for localized, soreness at the, injection site. Well, we had additional information beyond that. Now that they came from governmental sources. Now, when people showed up, that was our purpose, was to just expand it to more than just that one myocarditis, so that it implied that females didn't need to worry about it. Children didn't worry about it. There's no side effects other than young men and myocarditis is the implication of that form. And so what we're trying to do is just provide more, as he's mentioning, and most of that was from governmental entities. Well, when people showed up, there was people saying, "Oh, you're going to take away all vaccines." It's like, and I was sitting here and they're going, "No, we're not taking away all vaccines." And I couldn't believe where the direction of that conversation went, and there was way more emotion in the room beyond what we had presented. We were trying to fully inform anyone who comes in the risks and the benefits as he's projecting here. And that's what informed consent means in every medical institution, and that's all we were trying to do. But there was so much emotion in the room, and then pediatricians coming in and pediatrician offices making accusations that I'd never given vaccines in my career, and not very many, or I don't know much about vaccines. It was, the emotions were out of touch with reality. And so that was not a reflection of the emotions that were in the room that day were not a reflection of what we were trying to do.
I do have the packet of information. I have the packet of information that was presented as informed.
Well, no.
And I don't have it with me. We've already been here 3 hours. I actually have a trip I'm going on.
Oh, yay.
So I really would have liked to have
Well,
gone
well,
a half hour ago. So if this group that is here chooses to take action, that is your choice. For myself as a board member, with the information I heard from multiple people, I definitely need more information on what, I like your definition, but I would like more information.
So
And by the way, the packet was an example. It was not meant to be the definition thereof. It was an example. It was being proposed as, since there's more information from governmental organizations other than this slip that's downstairs, shouldn't we provide informed consent? And that it was never intended to be the final definition. It was never intended. There's just additional information out there.
So one thing with the idea of the Nuremberg Code is, I know that might sound, maybe unfortunately a lot of people don't actually know what that means. Like in medicine, you probably have learned about it, but just the average person may not actually really know what that means. And so one option, rather than kind of have a term that people don't understand, is we could make like a friendly amendment to where we list out the actual points of that are just written out on there, which is basically the importance of any public health institution is to follow those. So one of the things is, then this probably highlights somewhat of the dichotomy between the physician and the public health institution. So there was a public health institution article that I looked up back maybe, 5 years ago. And I was trying to study the philosophy of public health versus being a physician and why they were kind of running into some collisions there. And it said in there that public health people should be aware of the physician who has the Hippocratic Oath and has individual oath to the individual patient, that the physician might become the public health's opposition, because of the public health is not always concerned about the individual; they're concerned about the public metric. It was in a public health journal's own discussion process on beware of the physician and the individual provider, because they are loyal to the patient and not to the public health metric. And so that is something that we should all be willing to at least think about and talk about and discuss. And so that's where there tends to be like a public health circling the wagons. Maybe the physicians are circling their wagons. We realize that there's a truth of, I think, learning how to work together so that we actually develop a healthy public, not try to do things to public to tell them they're healthy. Does that make sense?
Yes, and I think definitely we're all in agreement about protecting and promoting the health of all
Yeah.
the residents of North Idaho.
Yeah,
Mhm.
amen to that.
And that's the only thing that the bylaws changes incorporate.
Mhm.
There is no specific agenda, Peggy.
Mhm.
It's a moral principle.
I did not say there was a specific agenda.
You said you
Did
need
not
more
say that.
The
information.
Nuremberg trial did not talk about vaccines. It talked about risk and benefits of intervening on human beings. Do we hear a motion? There is language. Do you want to modify the language or are you
I'm
accepting?
just trying to look at, is that the same as last time?
Yes.
Yeah, I'm just trying to look at where that exact is. So on page 41. Good trip. So the modification here, because this is the actual, so this is like what the proposed new director bylaws, is that right? What's on? What's the?
We no longer have a quorum.
No, oh, Melissa's not here?
Nope.
Oh, okay.
Is Melissa here?
We're stuck till next time. We can't leave.
Okay. So we can't.
You just,
Can't adjourn.
No.
We can't even move to adjourn.
We better call DoorDash, so. Okay, see you, dude. On that case.
They can move to adjourn.
okay, we'll see you. Let the record reflect that Peggy Cavallo
Broke quorum.
just left in the middle of a discussion of a motion. Well, it's a true statement. All right, I guess we don't even have a motion to adjourn. We're now down to 2.
We're now down to 2.
Well, everyone, I don't know. What do we do, Ron? No. Well, I will take I guess, chairman's prerogative. The meeting is adjourned.
All right, there we go.
Wow, that's profound.
All right, we'll keep on.
I will, I've got calls into Jessica and another person that I dealt with. My hunch is that it's going to be okay, but if it's not okay, you'll be the first one to find out.
Okay, yeah, and, I think when we talked with them before, they have their criteria, right, their general criteria, but at this point, the agreement that we're looking at is a specific, it's a narrow scope, and so